So nutritional topics, they go anywhere from anorexia, bulimia, severe malnourishment due to Alzheimer's, nutritional referrals, things of that nature. So I'll just hit it slide by slide. All right, so severe malnourishment. I'm going to do this really quick. Brittle nails, always iron deficiency, protein deficiency, thinning and hair loss, fatty acids, dermatitis, vitamin K deficiency, bruising. Don't forget those things. It's going to trickle into your NCLEX. It's going to trickle into your HESI. It's going to determine your answer, right? So you're going to see a question that's going to say, Sally, who sells seashells by the seashore, came in with da-da-da-da-da, da-da-da-da, and brittle nails. And then all your answer bank questions, or all your answers that are options, are going to have disease processes on there. But one of them is only going to be specific to iron deficiency, so you have to connect the dots. But guys, you got this. I'm not even stressing over this at all. This is going to be our best grade yet. So make sure that you're paying attention to that. Understand the concept. Move along. So first action when you're determining if a patient is following any specific religious guideline that's going to impact their nutrition. That is from a basic assessment whenever you have a severe malnourished patient. You need to make sure, first and foremost, what's your religious preference? What are we eating here? What are we not eating here? Because it's the basis of how we're going to get through this, right? So obviously it would be the first thing. So make sure that you also understand that just because someone has a religious preference or they're a certain religious denomination, that doesn't mean they're going to follow all the practices, right? Like, not all people, who have no pork in their religion, truly follow that, depending on what generation you're in. We've all seen it. People during Lent, sometimes they pick something that's super important, sometimes they don't. It's just, it's a discussion that needs to be had and honestly to be celebrated. It's an opportunity to ask questions and realize how small we are in the world. I mean, to say that we're grains of sand on a beach is really, really putting it a little bit more magnanimous than I would like for it to be, because it's so microscopic, the ratio between, this universe and where we stand. So I challenge you to learn from all of these individuals, right? They have a lot to teach us, and there's always something to learn in this world. And people have an inherent need to be needed, and they have an inherent want to be wanted. Even robots like me, I swear. Maybe not. Yeah, okay, fine, I'll give it to you. I'm a hybrid. So this is important because it's the basis of our humanity and who we decide we're going to be to the core of our being. And the more we learn about other people, the more we realize who we truly are. And we're going to end up finding during a state of nirvana and, this revelation that the answer is we're all related and we're all together and we're all of one blood and we're all of one thought process. So the similarities far exceed the differences. Okay. Now that I've thrown a knowledge bomb on you that was completely unnecessary, we'll move on. It's our last discussion. It's our last talk and I'm going to miss it. I'm going to miss it and I'm going to miss you guys. And this sucks. So I want to throw all of my little nuggies in that I can give you last minute, right? Because after this, you guys don't need me no more. You guys got Willis. He's going to take care of everything. So if I get a little weird, get over yourselves. I have Asperger's. You guys know this. Hopefully you're laughing and not calling HR. So ask your patients about food preferences. Put those into consideration. Not all people practice the same thing. Duh. All right, so determine who shops for groceries and prepares the meals. If you hear somebody's living with their daughter, cool. I'm glad. You have dementia, you have a malnourishment issue, you live with your daughter. I'm going to look right at your daughter and look at you, and I'm going to go, okay, cool. So who gets your food? Who shops? Who cooks? Who's in control of the diet? Because if you have Alzheimer's, it might not necessarily be you, right? Make sure that family member is involved with the teaching and discussion, because that's going to create a bond of trust between the two of you. And it's going to lighten the load of the grip that a helicopter daughter or son or mother or father is going to put on you and that patient. There's going to be a lot of separation in the very beginning because they're going to be watching you like a flinging hawk. So be relaxed, be yourself. Don't do the things that corporate America is going to tell you to do. right? Don't do the, hi, my name is so-and-so, and I'm a nurse, and what can I do for you today? Come on, that's super cute, and that's on our little, like, last-minute sim that we get graded for, and that's just, revolutionary. But it is the most benign, ridiculous thing that I can ever think of, and it's incredibly remedial and missionary, dare I say. So let's make sure that we, just be ourselves, because it's going to be fine. We need to know also that we're teaching the education we need to teach them, and also that they understand. So we kind of have to do a cognitive assessment and understand within ourselves, what kind of reading level does this person have, right? Because a lot of times older family members who take care of their adult parents, or elderly parents, they're going to understand very quickly that there's a lot to be remembered, and it gets really confusing, and they lose a lot of their ability for memory, recall, and cognition. So this is why I say you absolutely need to get them involved, teach and discuss things, and talk about those needs so that everyone understands what's going on. All right, next slide. All right, so anorexia, bulimia. I feel like I have hit anorexia and bulimia so much more than I need to, but it's such a big deal to me. So I really, really hit hard on it. Here's what I need for you to really focus on and hone in on with anorexia. Your laboratory tests are going to reveal hypokalemia and iron deficiency anemia. So your number one problem with this patient is they are at a huge risk for electrolyte imbalance. That's their nursing diagnosis. No ifs, ands, or buts, right? Also, because we have hypokalemia, of course, if we're 88 pounds and we have a dysrhythmia of any sort and we're sick, because usually you're immunosuppressed when you have this issue. Think Brittany Murphy, if you guys are old enough to do that. It's the Gallon 8 Mile that was Eminem's girlfriend. She died from anorexia and getting sick, very mildly sick. But what really happened is she was hypokalemic because she was, bulimia and anorexia, and in that process, she had a cardiac dysrhythmia, and that's what took her out, supposedly. Now, I know there was conspiracy about poison and this and that and the other and yada yada, but from a legal standpoint, this is how she passed, and it makes perfect sense for it to be that way, looking at all this. So remember, cardiac dysrhythmias, teeny tiny people, they're hand in hand. You got a high heart rate, you got a low blood pressure, you don't breathe very well because you're completely anemic, and you also have a massive folic acid deficiency, protein deficiency, so you're going to have all kinds of issues. Go back to the last slide, minus the part where I almost teared up. Almost. Too tough for it. Robots don't leak. Don't think about it. Go back and remember what attaches to what. Remember brittle nails, iron, yada, yada, yada. Okay? And then you should be good for this, and then you can move on. All right, you need to refer the dietitian for any complete nutritional assessment. Like if you have anyone that has weight fluctuations, like they lose weight, then they gain weight, then lose weight, they gain weight, something's going on. Maybe they're forgetting to eat during certain times of the week. Maybe they're busy during certain times of the week, or maybe they can't afford it after so many days after they paid all their bills. So then they drop 10 pounds and you just happen to get them at that time, right? People are weird. They have a lot of pride. I don't get that, but whatever. People have a lot of pride. Pride consumes them. And part of this is I don't want to admit the fact that I'm older, and I don't want to admit the fact that I'm deteriorating. Like where I come from, aging and deteriorating means that you are one with the ancestors, and you have ancestral knowledge that goes on thousands of years. So if that means I'm going to get some wrinkles, cool. Like, all right, that's fair. So think about it, guys. My little young bloods that are still learning things in this world. So weight fluctuations, use of corticosteroids, rheumatoid arthritis, things of that nature, right? Vomiting in the last 5 days. I don't care about 2 or 3. 2 or 3 is meh, whatever. We start to really lose our fluids and our electrolyte imbalances when we've had a solid 3 days of being truly sick, if you are a truly healthy person with no disease complications, right? So any infected wounds that are having any issues at all or draining, all of these people are at risk for malnutrition, right? So what we need to do is we need to make sure that A, they're able to absorb nutrients, B, that, we offer them any type of sustenance beyond what they normally eat. And C, we monitor and we record. That's the biggest deal. So long-term residual difficulty with absorption of nutrients for post-surgical patients, right? Small bowel resections will cause malabsorption. What's a small bowel resection? It's where I cut off, I don't know, 1.5 feet of your intestine. And that 1.5 feet is important to motility because as we go down the line, those little fingers, that villi and microvilli, right? Those guys are rolling around and they're grabbing things and they're absorbing them. So if I have less intestine, I have less absorption, aka malabsorption, aka I don't get my nutrients, aka I need nutritional referral. See how it all flips back? It's super simple. So small intestine responsible for absorption of most nutrients. The removal of the segment obviously yields a decreased area with which we can actually absorb those nutrients, just like we just said. Get nutritional supplement between meals for this patient. If you don't have time, guys, listen to this, write this down. If you don't have time to give someone their prescribed nutritional supplement between meals, then you need to utilize your unlicensed assisted personnel or your nursing aide or whatever you want to call them, SDNA. You need to get these guys involved because they can sit in there and do that while we're running around trying to make sure someone doesn't have a heart rate at 199 anymore. Okay? So make sure you understand that. Don't abuse your power, right? Or you're going to get it back in this world. I'm throwing a lot of knowledge bombs. I'm so sorry it's worth the extra 30 seconds to me. It might not be to you, but maybe it'll kick in 20 years from now. Maybe. Don't abuse your power, right? Texts will really ruin your day. Texts will work with Dietary and they will work with front reception and they will work with the nurse manager incognito to absolutely decimate your day if you act like a jerk to them. And you know what? Shame on you, and it serves you right. How about that? And guess what? The universe feels the same. So anytime you put something into this world, make sure that the second you speak it, you have legally and effectively obligated yourself to you saying that has been manifested into existence, and you have the choice to make it a good existence or a terrible one, right? So by doing that, you need to make sure that you're creating a balance and you don't want to tip the scales in the wrong direction. So try to do the right thing. If it's right in your heart at the moment, even if it's wrong, it was done with good intention. It's an even balance. Do something maliciously to hurt somebody, you're fair game. It's open season, okay? And it'll happen to you financially, physically, mentally, emotionally, and spiritually. So good luck with that. I think I'm done with this slide. Remember those nutritional referrals. Remember why we would need those nutritional referrals, like what's wrong, the top bar that we have. All right, next slide. Okay, iron deficiency anemia. Iron deficiency anemia needs iron. Cool. All right, so what's high in iron? Red meats, livers. Who the heck eats liver anymore? Oh my God, this isn't 1842. Oysters, kidney beans, whole wheat bread, not white bread. One more time. Not white bread. One more time. Not white bread. Egg yolks. Not egg whites. Not egg whites. Nope. White is not cool in this case, right? Nothing special about it. Egg yolks, whole wheat bread, not whites. Cool. Spinach and apricots. Apricots, that's interesting. Apricots have as much iron, believe it or not, as a small serving of a red meat. So how about that? So there's your little fruit buddy, is your apricot. Your cute little apricot fruit buddy. All right. You guys probably think I'm crazy, but when you do this final, you're going to be laughing the whole way through because it's all going to make sense. All right. Dementia risk for malnutrition. Now, I need for you to figure out if the patient's a proper historian, aka, do you know what you're saying and do you mean it and are you right? Can I trust it? Okay, so you need to let them know, or you need to ask them, can you tell me the food that you ate yesterday? And if they truly have Alzheimer's and they are truly a terrible historian, they will look up at the ceiling and try to fake I'm thinking about it, but I'm super perplexed and I don't even know what's going on. I think the answer should be green. They're trying to mask all of those thoughts in their brain by way of a small eye gesture. Okay? So when you see that, that's an automatic signal for that's a hard fail. That's a hard stop, move on. Okay? This is all I got for iron. All right, so when we're talking about protein diets that are high in protein that we need for, our Alzheimer's patients or our patients with wounds, whatever the case may be, please know that looks are deceiving. So if you notice an ounce of Swiss cheese is 7 grams, 2 tablespoons of peanut butter is 9, 1 cup of cottage cheese is 31 grams of protein. Old people love eating cottage cheese. It's cold. It don't hurt their mouth. It's mushy. It has a taste-ish. It's good. It helps them poop, and old people love to poop. So make sure that you understand which one of these has the most protein, and make sure that you don't mistake it for something that doesn't. And that's all I got for this slide. All right, NG tubes. NG tubes are part of a couple of things. It's part of fixing malnourishment issues. It's also part of sucking things out that don't need to be in, right? AKA a bleed. So when we're caring with a patient with an NG tube, number one, keep head elevated 30 to 45 degrees. Like that's all there is to it. I got nothing else to add. Tubes are less likely to cause mucosal damage with the stiffer tubes. So like the 14 French is what they mean by that. It's used for nasogastric suction as well. A lot of people think that there is an expiration date on these things. There technically is, but technically isn't. So some hospitals at one point were trying to change these things every 3 days. Could you imagine somebody putting one of these things in and out of you every 3 days? Every 3 days you feel like you're drowning? No, that's not a thing. So the way it works now is if it's clotting, if it's coagulated in any way, if it's causing discomfort or they're having trouble breathing, yank it and put in a new one and bridle it. Bridle is a little thing that kind of holds it to the nose, right, for long-term people. Make sure that medications have to be flushed before. The medication's completely crushed to powder. Don't you put in little pieces and bits. That drives me nutso, because these guys then have to go into the doctor, have them yank it out and throw it back in. All the while, all you're doing is sitting there watching, I don't know, another episode of something that you're streaming and binging. So how dare you, right? Take the extra 2 seconds to crush it up really, really fine into powder, and then mix it with the fluid. Make sure it goes down smooth, and then flush it again. Okay, that's how that works. It avoids clogging. There's no other way around it. Don't mix medications with formula. So the 2 clogged tubes, and here's why. A lot of these formulas have a filler in it and an additive that when it reacts to certain additives in medications actually thickens up the entire mixture, and that's how we get the clogs, right? Or it crystallizes, which is a bigger issue, right? So this is why we say these things and why we do these things. Okay, so I'm actually going to go into fears related to getting better. Patients are afraid to get better. Sometimes, okay, so you know how I always call myself Dumbo's feather, right? Because you don't need me, you just think you do. Okay, your patients are going to do this to you too. And then you're going to realize, oh my God, it's like I call you my children because you quite literally are my children, because it feels like I'm raising kids. And it's not mean, right? I enjoy you. Like, I love kids. Everybody knows that, right? I'm a giant kid myself. Like, I'm a grown 40-year-old who's highly intelligent, right? Socially awkward, and is a 10-year-old child. Like, I am what I am. It's cool. So I say these things because people are going to have the same fear, and you're hopefully going to have the same love that I have for this craft and for other people and humanity, because it's just fun. Life is fun. Life is funny, and life is fun, even on the bad days. So try to have a little joy. So these guys are going to be terrified to leave you. They're going to feel like they can't do it themselves. They're not going to be able to do it in a healthcare facility. If they're coming out of the healthcare facility, or ECF is what they traditionally call it, then they're going to feel like they can't do it at home. Like, it's that big old deal. So you have to reassure them, right? They're going to think that they can't manage tube feedings, right? That's a big fear. I remember, you guys know a lot about me. You don't know a whole lot, but more than most people I've ever met know, because I keep it quiet, but I feel like it's fair while we're bonding and getting to know each other. So I had a stepsister named Joey, and she was born with spina bifida, and she was trached and pegged, and She was tubed and all the fun stuff, so I learned a lot. I got a lot of operating instruction on this. When we are dealing with tube feedings at home, everyone wants to sterilize everything because they don't want to touch anything because they think they're going to kill somebody. One of the main things I can tell you when we're talking to people about tube feedings is let them know this is not a sterile technique. You are not going to do anything to infect them. These are intestines. Intestines are meant to deal with waste or bugs, right? There's bugs that live in our intestine. It's okay. And then once you tell them that, they calm down. That's the big deal. And I know that because that was the biggest fear with Joey, right? My stepsister. So, while she was alive, she learned how to do it over time. But, when she was little teeny tiny, it fell on, my stepdad and bio mom who did the best that they could, right? But lived in fear quite a bit and unnecessarily took her to the hospital a lot. As she complained about it, it was something that really messed her ability to just be a normal person. So think about those things. Therapeutic communication. How do we figure out what's truly wrong with them? Because they might be irritable, right? So you start with the tell me more game, right? So can you tell me more about what's going on? That should be good enough. Can you tell me more about what concerns you have going home, right? These are super important questions that you need to ask to get right to the point. There's no hem-hawing about it. We know it, we understand it, we feel it, and then we can move forward and fix that and make them adjust. All right, now we're going to move into lower GI. We're going to focus on constipation, diarrhea, ileus, I believe, and a whole bunch of other things. So here we go. All right, constipation. Chronic constipation, you got to avoid things, right? And then you want to make sure that you're doing all the things that you can do to have the best outcome that you can have. So number one is you cannot take stimulant laxatives or saline laxatives frequently. These should be used infrequently, as in you use it maybe once a month, because if you overuse them, then you have rebound constipation if you miss one dose. Right? This is why old people freak out about their intestines all the time and say that they need an enema because I haven't pooped and it's been 15 minutes since I ate. That was a conversation I had last month. I'm not even playing with you. And she was completely cognizant, right? Like this is a cultural thing. This is a environmental thing, right? So make sure that we're educating them to not use them. They should be used infrequently, okay? In order to avoid chronic constipation, use bulk laxatives, like AKA fiber, use early morning timing to go potty, bowel training, exercise for paracelsus, right? I've already said it a million times, and avoid over-the-counter medications that'll keep them constipated. All right, diarrhea. Yeah, people poop and it's watery, and usually you say cha-cha-cha at the end if you want to be super sarcastic. What are you going to say about this that we don't already know? It leads to electrolyte imbalances. If it's done over time, it leads to significant weight loss. It leads to dehydration, right? All the things. So what's the cure-all? Imodium. And it is loperamide, and I might have said that wrong. I don't think I did, though. Imodium is good enough. So it's our antidiarrheal agent. It's going to manage acute and chronic diarrhea with inflammatory bowel disease, with, resections of the colon, with a lot of different people. It can also be used to reduce the volume of the drainage from the ileostomy, and this is because of a motility and gastric juice and leptin and ghrelin return. Remember, ghrelin makes your stomach growl, which means you're hungry. Leptin means leave me alone, I'm full. It's that receptor, so we have less fluid and it's more manageable and we're not so embarrassed. The only time that Imodium is has a major contraindication. Good Lord, I can't even talk right now. What's wrong with me? I'm tired. So contraindications to this is if you suspect C. diff, don't you dare give them any Imodium, right? You need to get that specimen first, because if it has any bit of solidity in it at all, they're going to count it as a negative and move on, and they might actually have it. You just gave them a dose of Imodium. So make sure you don't do any of that until you actually get that specimen. All right, irritable bowel syndrome. gastrointestinal disorder, recurrent diarrhea, constipation, abdominal pain, bloating, irritability, discomfort. All those are things that go in with it as well. It is anything that has a diagnosis of irritable bowel syndrome. It's going to be present for the last 3 months, right? So we need to ask them specifically when they give us a complaint of abdominal pain and recurrent, diarrhea or recurrent constipation and diarrhea. How long have you had this pain? How long have you had this issue? Because if they say I've had it for a year, we know it's IBS, right? If they say they've had it for 7 days or 5 days or 2 days, we might be thinking, oh, we got big problems here, right? So that's the number one question, and you need to know that, right? Like, I think that's a fair thing you need to understand. Abdominal distension, breaking wind, if you will, food intolerance, all associated with IBS. But it's not part of the diagnostic criteria, so please understand that it could be something different. Fiber help produce bulky, soft stools and establish regular elimination habits. So you should consume a high fiber diet. My day group is like, no, that's not what she said. And you're right. That is not what I said. I told you guys exactly the opposite thing because what I was thinking in my brain was different than what came out of my mouth. And I just realized that as I was saying that sentence. So what I meant to say was consuming a high fiber diet when you have irritable bowel syndrome regulates, right? So like if you got one extreme and the other extreme, this is teeter-tottering and balancing it by way of this type of fiber producing stool, right? So that it all mitigates itself. It all attaches to itself and it fixes, right? So that it all goes and travels the same direction at the same time. So I hope that's easier to understand. It probably isn't. I talk too much, but please understand, you should consume a high fiber diet, right? Eat regular meals, drink 8 to 10 cups of liquid a day, chew the food slowly so that it doesn't get hard, then too soft. Make sure that you are doing things in a natural, balanced fashion is the key comeback on this, right? Medication therapy, it just depends on IBS. Sometimes you got to do Lomotil. Sometimes you can just do Imodium and that's enough. So bulk forming laxatives or antidiarrheal agents for people with IBS, they need to be prescribed. So please understand that. You can't just go to the pharmacy and decide that you've got IBS and decide what fixes it, because 9 times out of 10, what actually you think fixes it makes it worse. All right, C. diff is easy to go through, so I'm just going to blow through it. C. diff, highly contagious spore. Lasts for up to 5 months in inanimate surfaces. I'm not even joking right now. I just looked at that today. That was from the CDC. Patients should be placed in a private room. Contact plus, contact plus, contact plus. There's no need to restrict dietary products for this. Flagyl is usually used to treat it. And proper food handling and storage is not the reason. People have, the last year and a half, 2 years, whenever someone's got C. diff, some family member always comes by, asks what the contaminant is and why they're contagious, and then says, oh my God, they're so dirty. Like, this isn't a thing about food handling or storage or being dirty. This is a spore. So the richest, most clean OCD person in the world can get this. So it's not about money or how you keep your house. That's not a thing. So please understand that as well. All right. So when we're dealing with polyps, anyone who has a family history of polyps, it greatly increases their risk of colorectal cancer. You need to know that. You need to know it. You need to know it. There's no way around it. It's going to come back on the NCLEX. Okay. This is a condition that has somebody in a colostomy by the time they're 25. I had one girl that I was in school with, and she had this little guy that she was just crushing on hardcore. We were sophomores in nursing school. Yeah, she was adorable. And she went out on a date with this boy who was a nursing student as well. And she was just fanatical about this guy. She's just been McDreamying over this guy for years, right? He goes out with her and they really enjoy each other. And then she comes crying one day and looks at me and says, what am I going to do? And I said, what do you mean? It went great. And she goes, but I have a bag. And I was like, you have a bag, like you have baggage? Well, we all have baggage. And she's like, no, I have an ostomy bag. What am I going to do? And I was like, oh, hell. I don't know, buddy. What are you going to do? Well, they're married with 2 kids now, so it's cool. But it was a really big deal because, she was in her 20s. So understand that these guys will start getting yearly colonoscopies starting at like 15, 16 years old. And I'm talking on the dime yearly. They're not missing that appointment at all because it's just a matter of time. And it's very unfortunate. It really, really is. Remember, polyps, they grow from the inside out into the intestinal, the internal intestinal line, not the external, right? Because it grows from the inside out. So by the time we see it, it's already super deep, okay? You have to have a DNA analysis to make the diagnosis, period, right? Lifestyle modifications are not going to decrease your risk for cancer in this patient. This is a genetic mutation, okay? Remember also, polyps, they commonly bleed after a bowel movement. So we cannot totally trust the fecal occult to let us know if there's true presence of blood in the stool, which is why we also have these frequent colorectal cancer screenings, okay, and these frequent colonoscopies. So we were talking about NG tubes earlier. I'm going back to NG tubes briefly. Intestinal obstruction is a big deal. Distension, vomiting, abdominal pain. Few of the symptoms associated with an intestinal obstruction. So if someone comes in with distension, vomiting, and abdominal pain, we got a problem. NG tube insertion and placing them on NPO is going to be the expected order. Number 1, done. Nasogastric tubes, sometimes they belch a patient, so they remove the gas from them, from the stomach. They put it on low intermittent suction, and it just kind of gets every bit of gastritis issues out. Or when you're dealing with a true obstruction, the gas doesn't go anywhere, so it compacts, and it's miserable. The bowel sounds return to normal, and if you have sounds in all of the quadrants, then that is your cue to go ahead and start removing that NG tube, but not a minute before, okay? What's going to happen if you remove it too soon is you're going to have return of old bowel function. It's going to creep back on you, and it's going to get worse because it's going to get pissed that it almost beats you, right? Like, fold again, I'm coming back for round 2. It's that type of a deal, so it'll get worse really quick. Make sure that you understand serum electrolyte levels, pH of gastric aspirate, tube placement are important assessments for the client with the NG tube in place, but it's not going to assist in determining if it's time to remove the NG tube, okay? So gastric aspirate's down. I don't care, right? Do I have quadrant sounds? Period. All the other things are just pieces of shenanigans. A lot of times we keep it in for too long because of serum electrolyte levels, and we could have already taken it out. Again, that is not a true assessment. Checking those bowel sounds in all quadrants is. All right, life-threatening concerns, hypovolemic shock. This is abdominal distension concomitant with tachycardia. You got a patient, I don't care if they're 15, if they're 30, if they're 45, if they're 145. If they've got abdominal distension and tachycardia that's brand new, then this is just hypovolemic shock. It causes problems like peritonitis or intestinal obstruction, all of which are terrible and could kill you. And it requires rapid intervention. Do not ignore this. This is your top priority. And that's all I have to say about that. All right, so we're going to move into neurological problems. So let's start with cluster headaches. Cluster headaches. Headaches come in episodes or clusters that can last from weeks to months or days, depending. It's not associated with the trigger. It's not associated with food stress, hormonal changes, none of that, okay? It is common to awaken in the night with severe stabbing headache when you have a cluster headache, all right? It's because there's a transition from REM sleep, which is your deep, deep sleep, to the non-REM, and that might have something to do with an attack because of acute dilation, depending on if you were having what they believe might be the equivalent of a nightmare or a very vivid dream. Okay, so when you swap from what I call the spiritual side, dreams where we come from, or just the ancestral side where, everyone's past, right? Like that's just going back over there, whatever. So it's like from going over there and then just going straight back into the matrix without any type of time for contingency, right? It's just do or die. This is what triggers this event. And they wake up with blistering, stabbing headaches. So how do we fix this? Well, first we need to know what causes it. So this transition could be from apnea and just sleeping too darn deep, right? Could be from like a hypothalamic abnormality, which is usually the case sometimes. Usually the case sometimes. Okay, oxymoronical, whatever. Acute treatment either way is going to be hyperoxygenation for 6 to 8 minutes. Usually within 15 to 20 minutes, they will start to get relief, and by 60 to 90, it'll pretty much be over altogether. So that's why we have to do the acute hyperoxygenation. Plus, if we got apnea, that runs into a lot of other issues, right? So these guys who have these cluster headaches and complain of them, make sure that we're discharging them with a sleep study order. If the patient gets relief off of the oxygen, you don't have to call the doc, right? Like, you gave them what they needed. It's going to be a standard order for you to be able to give someone oxygen if they need it. And if they're having this blistering headache and you know what we're dealing with, it's cool. It's only going to last a minute and a half. 6 to 8 liters at a minute and a half is not going to affect anybody long term, even if they are the worst COPD that ever existed, right? Sometimes you just got to give them a minute of some good stuff and they're good. Let's see. Hot packs, helpful for the tension, are not likely to reduce pain associated with the cluster headache. Okay, this is a tension headache situation for hot packs. And I would argue that tension headaches, cold is probably better, but whatever. Just know that fact, that are not likely to reduce pain associated with cluster headaches when we're talking about heat. All right, migraines. We all know about migraines, right? So it's temporary changes in the nerves, chemicals, vessels in the brain. Sometimes you need to chill it out and calm it down before it becomes a big deal. So what do we tell you? Go to blackout mode. Dark room, right? Quiet area. Cold, not hot. Hot sucks. Hot dilates. Dilating is the problem, so we need to constrict. No loud noises unless you want to get kicked when your patient gets better. That's going to happen if you yell. Topamax. Topamax is a great medication, but it has to be taken for several months to actually be effective towards migraines. So giving a dose of Topamax to a patient with a massive migraine in a hospital setting, I want you to roll your eyes at that doctor because he's an idiot. Because this happens all the time. People go, migraines, Topamax. No, dude, it doesn't work that way. It's got to be taken like SSRI, right? Like 6 to 8 weeks is when we start to see results, sometimes even longer. Aspirin, believe it or not, or NSAIDs can be taken with triptans, which is what we actually use that work really well. So your Imitrexes and things of that nature, Fioricet. Alcohol makes migraines worse. Please understand that. And migraines are not a mini stroke. Oh my God, the nerve of some people. So this is a common myth, and I don't know why, but they're like, oh, you're getting a migraine. That tells you you're having a stroke. No, dummy. Here's the difference. A migraine lasts days and days. It's debilitating. You can barely move. A headache associated with hypertension, which is associated with you about to pop a nerve in the circle of Willis or vesicle and, blow a hole in a gasket and have a subarachnoid event. It's completely different. Completely different entities. They're not mutually exclusive. So please understand that. Migraines are not mini strokes. Alcohol makes them worse. Aspirin can be taken with triptans, and so can NSAIDs. And Topamax is basically useless for 6 months. All right, seizures. Oh boy. Let's talk about pseudoseizures. Pseudoseizures is a nice way of saying you're faking. It's a nice way to tell a doctor, this guy's nuts. And not nuts in a literal nuts, they're crazy. Like nuts, like this person is crazy thinking that we're not going to know, right? So if they are physically crying, I can't make this up. If they are physically crying, they are not having a seizure, okay? Asynchronous side-to-side movements. If your doll eyes aren't tracking left to right, left to right, left to right, and they're just kind of going everywhere, that's a nice attempt, but no, sir, no kindly. When you are trying to open their eyes, we will often try to pry their eye open in this event, and you will feel them squinting, and you're like, boy, I ought to right now. Let me tell you. You get really angry when that happens because you hold their eyeball up and it tracks, and they have pupil dilation, and then they have immediate like hyperdilation because they're like, oh man, I'm about to get caught. And then they just get quiet, and you look at them and you go, really? And you close their eye back. Usually they magically stop. I would encourage you to get that bowl when you're, 4 to 5 years as a nurse. It's a lot of fun. It really is. Because people calm down and they just learn to be themselves. Like, I don't know why we play games, whatever. So that's resistance to open eyes. Oh, the arm drop. I told you guys about the arm drop. So hold their arm up and let her go, and it's going to magically miss the face, or the pin test, which is putting the pin into the nail bed. That will be a positive assessment for pain, and you will know that your patient is perfectly fine. Record time, observe and record the details of the seizure and the post-ictal state. This is how we diagnose these. This is the most important piece that we need to know with seizures. Cool? Especially when we're going back to a doctor to give any other information. You may need to move the patient if they are in an unsafe area. Ativan's going to get rid of it, 2 milligrams usually. Make sure that you're not putting anything in the airway. This whole bite block business is for the birds. Don't stick anything into your mouth if you're having a seizure. Like, I feel like I don't need to say these things, guys, but yet I am. And yet it's a contingency point on Elsevier, which is a multi-million-dollar corporation that feels the need to let you know these things, because that many people lose their fingers sticking them in the mouth of a person having an active seizure who's biting their tongue off quite literally. So don't be silly, please, because I taught you, so it comes on me too if you do it. Okay? And seizure disorders. They are not a good diagnostic when you're using an EEG. You can't just catch a seizure mid-seizure. You will get brainwave activity that is reminiscent or abnormal, and that would be another indicator, but not a diagnostic completely. So it's all of these things mixed together. Just keep those things in mind. Specifically, don't stick your freaking fingers in somebody's mouth if they're having a seizure. That's crazy. All right, so Parkinson's, L-DOPA is your symptom relief. You must take multiple doses a day. You cannot miss a dose. If you miss a dose, you start to have symptoms again, right? So they are suppression medications, basically. It triggers all of your nociceptors to say, hey, snap out of it, act right, basically. So it's that big of a deal. In the morning, you're incredibly stiff, so you have to trigger remote memory by marching in place, right? Difficulty chewing is a big problem with people in Parkinson's. That's why they have like a flat effect, right? So we got to cut things in small pieces. And we also have to use an armchair when we are, getting the patient seated, so we can use the arms to assist getting up and getting down, right? So make sure that they go for that armchair, or they go for that arm as they're backing up into a chair. And we have to use an elevated toilet, right? This is simple physics. It's difficult for them to stand. It's easy for them to not. High protein foods, it will decrease the effectiveness of the L-DOPA. You guys need to know this. And it will increase constipation, and it will create a potential ileus. So know all of those things, right? Know what it does to L-DOPA and know how important that is. Parkinson's is steadily progressive. We all know that. And there's no cure for it at this time, but we're working on it. So next slide. All right, myasthenia. Myasthenia is a big problem. It is chronically autoimmune. It is a neuromuscular disease. It causes skeletal muscle weakness or shutdown completely. There's that. It's triggered by stress, surgery, adverse reactions to medications. IVIG, intravenous immunoglobulin, is what fixes it. It retroactivates the symptoms because we introduce new soldiers that they don't know, and those soldiers look at it. It's like the Bloods and the Crips. All right, cool. Let's do this because I graduated in Compton. I can talk about this. It's fine. So Bloods and Crips. All right, so the Bloods are my soldiers, and my soldiers don't like anything. So it's just fighting everything. It's like LA riots, right? It's like LA riots up in my body. And what happens is I get IVIG, and the IVIG represents, who's a benign group of people that I can't politically make problems with? Girl Scouts. Ha! So then I bring in Girl Scouts, and the Girl Scouts look at the Bloods, and they go, hey, we're not Crips, but I'm letting you know that we love you, and rather than beating you to death, we're going to hug you until you decide to sell our cookies with us. And then the Bloods go, oh man, you are real cute. You got thin mints. And then they're copacetic and cohesive. And that's how IVIG works. And I know this is the most random thing anyone's ever explained to you, but please understand that that's exactly how it goes. And there's no ifs, ands, or buts or in between. Okay. Know that myasthenia is a top to bottom disorder, as in the top goes first, which is why we get afraid, because we're going to lose airway. So impaired speaking, causing difficulty swallowing, affecting your ability to chew. If you change facial expressions, you've got to get to the hospital. A lot of these guys are going to be an elective intubation. So first and foremost, when you know these guys have exacerbation and they have a history of this, assess their respiratory effort. Assess their respiratory effort, assess their respiratory effort. It's first and foremost, and it's most important because they're going to die and none of this is going to matter if you don't assess the respiratory effort. All right, I've said my piece. Next slide. All right, restless legs. Basically, all you need to know is it is a big problem. It is excitability with your legs. There are medications for it. There are 1,001 of them. They absolutely need them. Don't be a jerk. Give them to them right before they go to bed. However, non-pharmacologically, we can fix this with regular exercise, believe it or not. But there are a lot of other concomitant factors that can stop them from that, aka diabetes, aka COPD, yada, 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 right? Like we all know these things. But in a perfect world, we could easily fix this with exercise. Antihistamines make it worse, so don't do it. Benadryl is not going to get you to sleep. It's going to spike you up and your legs are going to hate you. Okay? Massage isn't going to fix this either. It's going to piss it off more. Right? Because we are at that point hyper-focusing a bunch of nociceptors, aka someone muscle rubbing you, and triggering all of those motor neuron transmissions that piss off your RLS more. So let's not hit the beehive with a baseball bat, please. Thank you. All right. So it progresses in most patients more than likely because a lot of people don't know how to deal with this, right? It's not about non-compliance. Sometimes you just don't know. This is not associated with flaccid legs. Flaccid legs is loss of bowel or bladder. That is a spinal lesion, right? So if you see something about a spinal lesion anywhere in this world and flaccid legs, those go together, but you will not get restless legs with flaccid legs. We got a bigger problem. You got to look at them differently. You get any of that, we got problems. Remember, loss of function below the line of demarcation, aka the line of the lesion, means you have a permanent spinal injury and paralysis if that area is snapped. The cauda equina, those horsetails, those nerve endings, those really, really tiny, tiny little pieces and bits. If those get severed, and enough of them get severed, you got a hard road to toe, period. So make sure that you understand this is an emergency and you need to call the squad if you're out in the open, or if you're in the hospital setting, you need to go call your provider. Rheumatoid arthritis, autoimmune disorder, attacks the lining. It causes pain, inflammation, damage to cartilage and bone. It also damages your internal organs like your heart, your lungs, your nervous system. Most people don't know that, okay? Fingers are at a closed angle. So I want you to look at this hand. This hand is not bare pawed out. It is fused in. See the proximal knuckles? See how all of that and the distal phalanges, see how your metacarpals are kind of closed in, and the only thing that really separates your hands, like our hands, is the top, and that's only because they have these Swansgans necks. They also have a hitchhiker thumb, okay? Look at these and know these pieces and parts. You might see a picture and it might say, what is this? I'm just saying. This is a common occurrence and it's commonly mistaken for something else. This is not a medical emergency. The other thing is, okay? So this is what I want you to focus on because you're going to see this 9 out of 10 times. Most older people have rheumatoid arthritis. So this is going to be a common occurrence and this is the way you figure it out, right? Cold application is helpful in reduction because remember, cold takes care of inflammation. If you introduce heat to it, itis, inflamed, bad, right? In theory, people do use heat and it does work for them. I say do what works for you. And if it's manageable for you and your interpretation, go for it, buddy. I'm all for it. Because joint pain is chronic, they are supposed to exercise even when joints are painful. Now here goes my PM class because they're like, no, man, that's not what you said. You're right. That is not what I said. I was completely flogging wrong. And you're absolutely right. So my understanding of this was that we don't want to over-exacerbate the inflammation of the rheumatoid arthritis, when I did not realize that this is, in fact, an anti-inflammatory disease, which is not going to have any direct effect on those because it's going to happen regardless. Now, I am not a rheumatologist at all. I'm neurology. Everybody knows that. So am I going to screw up? Yeah, because guess what? I'm not perfect, and it's cool. I'm perfectly okay with that. So I apologize that I messed up your brain. I'm asking you to retrain your brain to remember that cold application is helpful, Patients are instructed to exercise even when joints are painful. Cool. Range of motion exercises, they're intended to strengthen the joints. Passive range of motion is not going to be sufficient. Recreational exercise is encouraged, but it is not a replacement for range of motion exercises. So you got to do all of the above, right? You got to do range of motion, but it can't be, this and that and the other. So make sure that you understand the differences. Just commit it to memory. It's only a couple of things. High dose aspirin for pain management. Monitor for GI bleed, obviously. Low dose aspirin for prevention. How about that? New studies from Mayo, Cleveland, and Johns Hopkins have all said the same. And that's all I got for this slide. Fibromyalgia. Okay, it's real. It's a gene expression. It's an autoimmune disorder. We found that out recently. Gabapentin is going to be your gold standard for medication. It used to be Lyrica. It's no good anymore. It caused a lot of problems. You're going to have sleep disturbances, multiple tender spots, widespread bilateral burning, musculoskeletal pain, right? It's going to feel like you just got shocked by, 150 volts. Late stages, that's when you get into the cognitive impairment, or what they call the slow brains. You're going to be forgetful. You're going to have difficulty concentrating, that type of a deal. Cardiac involvement and joint inflammation are typical. So here are the diagnostic criteria. You have to have at least 4 of the 5 areas. I don't want you to memorize this. I want you to look at it and understand it, and understand the why behind it and how it makes sense. If you notice, most of these are at a joint. And most joints are all added into these criteria. So yeah, look over it just so you understand it. All right, we're playing a dementia delirium game here because they look exactly alike, and I struggled memorizing these two as a nursing student. I don't know why, just because they look all like I'm a patterns person, right? Like that's how I do most of my statistical analysis is through simple patterns because I pick them up, right? This is what Asperger's people are good for, right? If you ever need to like look at bookie stuff from 15 years ago in gambling, like I'm your girl, right? This is the way it is. I'm great at numbers. So delirium and dementia look very, very clear. So I used to have to differentiate it with color like I'm doing with you guys. So delirium, sudden onset, less than 72 hours, related to UTIs. Hospital-acquired delirium happens to anybody. It's not just for old people. If you have that person that comes in and they were fine upon admission, and then, after a couple of days they start to have this issue, this is a delirium issue. This has got nothing to do with dementia. Please don't mistake the two. Old people will get cross-diagnosed back and forth a million times over. It's annoying. The degree of disorientation has nothing to do with delirium or dementia diagnosis. They are not mutually exclusive. You will have with dementia loss of recent and long-term memory. You need to remind the patient they're in a hospital and that they are safe. This goes back from the first exam. You guys know these things. Fragmented, incoherent speech. That can happen in either. Let's see. And I think I went over everything. Oh yeah, if your patient ever has a new cough and they're diagnosed with dementia, they're probably aspirating. You need to do something about that immediately. And that's all I got for that. All right, so here are cerebellar function tests. Cerebellum, back part of the head, responsible for walking, posture, balance, mental function, eye movement, speech, coordination, yada, yada, yada. Finger to nose test is how we check for it one way. And we're going to touch our nose, touch the provider's finger, go back and forth and back and forth. And as that's happening, they will potentially poke themselves in the eye. So make sure that they do it and have them touch their ear instead of their nose, because they end up poking their eye if it's a positive, and that's never good. Romberg test is what we call the falls test. So you basically close your eyes. Some people will have you lift one leg. Some people will have you close your eyes, throw your hands out in the air, do the Jesus pose, I call it, and lift a leg. It just depends. Either way, a positive result means they fall. So that is the biggest risk for this, and the biggest risk for a patient who has a positive test is falls. Okay? Makes sense, right? Because they fall. God, nursing is such common sense, and people just freak out about it and make it such a bigger deal than it needs to be. It's so annoying. I'm so glad that we had this time together so you guys understand that now. I'm so glad. You have no idea. So Romberg test does not assess orientation, thermoregulation, or discomfort, so we have to assess that separately. And then they have the arm swing gait test, and I think I've shown both classes, what that looks like. It can either be synchronous movements and swaying, which is weird, or it could be barely a swing or no swing at all, which is also weird. So if anyone's walking like Sasquatch, it's probably a cerebellar function. There you go. All right, dosage calculations. You got the head calculations, which is the, Timmy needs 5 milligrams, and we only have 10 milligram tablets. How many tablets she use? Like 0.5. Yeah, that's it for sure. Then you got your paper calculations, which is like, Timmy had 400 milliliters of this fluid over a period of 36 hours. How much fluid did they have total in liters? There's that, paper calculations. And there's like calculations, which is like, hey, we're doing a heparin drip over here, and I got this many units going on at such and such, going on at so-and-so. The complex calculation, there's going to be one in there. So just keep an ear out for it, learn it, memorize it. You guys are doing fine with this. I'm not worried about it.